Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is Borrelia Burgdorferi or Lyme disease. So Borrelia Burgdorferi is prevalent mainly across the USA, especially the Northeast, and across Europe as well. It does also occur in the UK, especially in the New Forest and in Exmoor, and because of its greater prevalence among wooded areas, hikers and campers are at particular risk. Borrelia Burgdorferi is a spirochete bacterium transmitted by deer and rodents, which act as the most common hosts for the ticks, which is of the Ixodes species. The disease can be prevented by removing ticks within 24 hours. There are 3 main stages to Lyme disease. So there's localized early infection, whose onset is 3 days to 1 month post-tick bite. 50 to 90% of cases have Erythema migrans, of which I will show a picture on the next page. And this tends to clear 2 to 6 weeks after the bite. The next stage is early disseminated disease, and this comprises secondary skin lesions, arthralgia, fatigue, lymphadenopathy. This happens a few days after the initial lesion. Lyme arthritis and aseptic meningitis may also occur during this stage. And finally, people may get late persistent infections, and this happens months to years after the initial tick bite, and this actually occurs in approximately 50% of patients who remain untreated. So here we have the classic Erythema migrans rash. You may have heard it being described as a target lesion or a bullseye lesion because of the way it appears. There are 4 main signs and symptoms to Lyme disease, which can be broadly classified into arthritis, carditis, skin, and CNS manifestations. So just looking into these in a little bit more depth, within arthritis, we may have a mono or an oligoarthritis of the large joints. Polyarthritis is relatively uncommon. Carditis can occur in 10% of cases, particularly in the USA, and tends to present as a dysrhythmia or heart block. And CNS manifestations can comprise meningitis, cranial nerve palsies, particularly affecting the 7th nerve, radiculopathy, chronic fatigue-type syndromes as well may occur. And finally, in the skin, you may see an acrodermatitis, which is described as an acrodermatitis chronicum atropicans. To diagnose Lyme disease, we require serology combined with a classic clinical picture. So the patients, for example, may give a classic history of going camping or going walking, particularly in areas where the ticks are known to inhabit, and they may also report history of a tick bite. 50% of patients with early disease will have negative serology markers, and in the case of CNS involvement, CSF needs to be sent for Borrelia Burgdorferi. The management of Lyme disease depends on whether the infection is mild or systemic. In mild cases, usually it's okay to give 2 to 3 weeks of doxycycline, but in more systemic cases, IV ceftriaxone is required. Okay, so now let's try a question. So a 20-year-old gentleman presents with a left-sided facial droop of 3 days duration. He reports feeling fatigued since returning from his summer holidays to Delaware. On examination, he is found to have a rash resembling a bullseye on his lower limbs. The lumbar puncture is positive for Borrelia PCR. What is the name of the rash? So your options are Erythema marginatum, Erythema migrans, Erythema nodosum, Erythema artefactum, and Erythema abigni. So you'll remember from our previous slides that the correct answer is Erythema migrans, which is also described as a bullseye or a target lesion. If you'd like to know more about any of these rashes, particularly Erythema nodosum, we do have some dedicated videos for these, which can be found in our dermatology playlist. I'll just link that up here for you. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.